Assalamu alaikum, everyone.
Walaikum assalam.
So we are live on the YouTube today, and let's continue with where we left yesterday. Over to you, Dr. Itzaz. I'm muting myself, and I'm here as a moderator only.
Thank you. Where should we start? Yes, please. From where we should start?
Did you see the BCQs that they did yesterday? Sorry,
Yes.
in the morning today?
Yes.
So a lot of them got the answers right, and that signals that they probably remember what was taught yesterday. And I think some of them did go through the review notes as well. So you can maybe start asking a few questions and then we can proceed.
Okay. There are just a review of surfaces, then we will proceed for the next one. That is the transverse section of the medulla oblongata, and then we will go through the surgical safe zones and how to plan the surgery, what structures we should be careful about that. Then we will summarize it. Okay. So yesterday we have discussed that the medulla oblongata have mainly, it is a conical type shape cylindrically. That's why it has the two surfaces, mainly the anterior and the posterior surface. This is the anterior surface of the medulla oblongata. Anteriorly, that faces the clivus, then the anterior part of the foramen magnum, and the posteriorly, when we see, it is covered by the cerebellum and the part of the foramen magnum. And anteriorly, it has also, when the odontoid process is there, the lower part of the medulla can also has the relation with the odontoid. So that's why it is when we are going to the transoral approach, there is some bit we can touch it. The anterior can be approached from here also. So this is the overview of it. So this is the, on the left side, this is the anterior surface, and the right side, this is the posterior surface. Anterior surface has, we had discussed earlier, anterior surface has 4 bumps bilaterally, 2 on the left side, 2 on the right side, and 5 sulci. Yesterday, deeply we have gone through, and now it's a bit review about that. So just I will ask, what is this sulcus? Anyone?
Anterior median.
Anterior median sulcus.
Anterior median. Excellent. This is the anterior median. So what about this one?
Anterior lateral.
This one?
This is anterior lateral sulcus.
Anterior lateral sulcus. Very good. And what about this one?
This is same anterior lateral sulcus.
Anterior lateral sulcus on the
opposite side.
Either side. So what about this one?
Posterior lateral sulcus.
Can you bring the laptop charge and give?
And this is the posterior lateral sulcus. Okay, bilaterally. So these are the 5 sulci, and on either side there are 2 bumps. This one and this one. This is the pyramid. This is olive. This is pyramid. This is olive. This is the posterior lateral sulcus. What is this structure?
Inferior cerebellar peduncle.
Inferior cerebellar peduncle. Just a part of inferior cerebellar peduncle is there. This is the posterior lateral sulcus. We have yesterday gone through this one, that on the anterior lateral sulcus, from here, that nerve arises. Which one?
12th.
Sorry?
12th hypoglossal nerve.
Hypoglossal nerve. And the posterior lateral sulcus, it gives rise to the 9th,
10th and 11th.
10th and 11th. Okay. So this is about the anterior surface, brief introduction. When we go through the posterior one, or the dorsal surface, it is a little bit tricky. It has 2 portions. Yesterday we have discussed that it has 2 portions. That is the demarcation line. We have yesterday seen that this one, superior portion of the posterior surface of the medulla oblongata and the inferior portion of the medulla oblongata. Superior portion, this forms some part of the floor of the 4th ventricle. This is very important. It is little bit identical and the mirror image of the, you can say, of the cone's posterior surface. When we look at this one, look at here. This is same. What we call it is the depression or sulcus. Yes, please.
Median
Posterior
sulcus.
central, posterior median.
Posterior. This is median sulcus, the posterior median sulcus. And what about this one? This is elevation.
Median eminence. Oh.
Medial eminence. And what is this sulcus? What about
Sulcus
this
limitans.
sulcus?
Sulcus
This is
limitans.
sulcus limitans. Excellent. And what about this sulcus?
Sulcus.
Yes, please. Yes, please. What about this sulcus? Anyone? This is, what about this sulcus? There's a posterior lateral sulcus.
Lateral
Okay.
sulcus.
Sorry?
Not the posterolateral sulcus.
Excellent. This is posterolateral sulcus. So the median sulcus, medial eminence, that is bump, and the sulcus limitans, and the posterolateral sulcus. This bulge that is in the bones, that is called the superior fovea. When we come down here, same structures here. This is called the inferior fovea. And this is the part of, you can say, the inferior cerebral peduncle. But the superior portion has three main triangles. The superior triangle, this one.
Hypoglossal
triangle.
triangle.
Hypoglossal triangle.
Hypoglossal triangle. Excellent. What about this one?
Vagal triangle.
Vagal triangle. And the last one, that is very smaller one.
Area
It
posterior.
has some demarcation here, but not figure here. That is the
Area posterior.
area posterior. Excellent. And only a small, this bulge is here. That is called the obex. That is the communication, direct communication with the central canal. So this is the superior portion. When you go through the inferior portion's anatomy is totally different from the superior anatomy. It is not correlated with the superior portion. The posterior portion, the posterior surface of the inferior portion of the medulla oblongata, it is mirror image of, you can say, the posterior column of the spinal cord. Same like that, the anterior surface, lower medulla is the mirror image of the anterior column of the spinal cord. So again, we have this one that is called the median
Sulcus.
fissure, posterior median fissure. And what about this bulge?
Fasciculus gracilis.
Gracilis, very good. And this one?
Cuneatus.
On laterally, this one? Cuneatus.
Cuneatus. Fasciculus.
This is the gracilis and this is the cuneatus. But the what happened? So 1 minute, please. So what about this one? This is the, when we talk about the cuneatus and gracilis, be aware of these two different things. This superior bulge, actually, this is more bulged area. That is from the superior side. These two bulged area, usually they are more bulged on the superior side. These are the area of the nuclei of the tuber, the cuneatus and the gracilis. But here, when you see the lower portion of the medulla oblongata posterior side, it is not so bulged. These are the tracts. That's why it's not so bulged. This is the area of nuclei. So there's a bump is there. On the other side, nucleus cuneatus and the nucleus gracilis are there. So up to here, any difficulty? Any
No, sir.
No. Should we proceed? Now, what happens? We will take the section from, when we transfer section, we get the transfer section of the medulla oblongata. Usually, we get the transfer section at the 3 to 4 levels. At the level of pyramid, at the level of medial lemniscus, at the level of olivary nucleus, And these are the different levels are there. But I will take only the one transverse section. Why? Because more or less the structure is same, just there is a difference of the nuclei. So we can put there that if we are going above, what kind of a nuclei could be there? If we are going downward, what kind of a nuclei will be there? Just we have to memorize. So if we are getting only one transverse section, not the others. This is same anatomy, just for the revision purpose. This is the pyramid. This is only the you can see the anterior surface of the or ventral surface of medulla oblongata, pyramid, olive. This is 12th nerve, 9th, 10th, 11th nerve. These are different structures we can see here. This is the cadaveric picture of sun. So this is the internal surface. Now, what we memorize just to imagine, map the imaginary figure of the parts of the anterior surface and the parts of the posterior surface anatomy, then it will be easy for us to put all the tracts, to put all the nuclei in the transverse section in the internal surface of you can say the medulla oblongata. It has two parts. That is the usually for the same like brain. That is the white matter and the gray matter. We know very well that white matter, it contains the tracts, ascending and descending tracts, and the nuclei is included in the gray matter. So look at here. So this is the, just I have drawn the one line, this, then it will be easy. This is the anterior part. This is the posterior one. Okay, now it will be easy for us to localize all structures. First, I will go through the sensory parts. You can see the sensory nuclei. So sensory nuclei, mostly the posterior column, it has the sensory one, and then the lateral column we can see there. So this is which structure? This part, this elevation. This is the posterior one. Excellent. This is gracilis. So this is the gracilis nuclei. Okay. So bilaterally, these are the gracilis nuclei. What about this one?
Cuneatus.
These are the cuneatus nuclei. Right? So when we talk about this one, this gracilis nucleus and the cuneatus, it has the fibers, the gracilis, G for the lower part, and the medially, G for genital. That's why I remember like this, the G for the genitals. That's why it is the lower part from the, it takes the sensation from the lower parts of the body, and the cuneatus from the upper part of the body. So it gives two types of the fibers. One, what kind of fibers? Yes, please.
Internal arcuate and external arcuate. External arcuate.
Internal arcuate and external arcuate. These are the
External arcuate.
These are external arcuate fibers. Where they will go?
Cerebellum.
They will go cerebellum through the.
Inferior cerebellar peduncle.
This is part of the inferior cerebellar peduncle. This one. This is inferior cerebellar peduncle. These fibers which go through with the help of inferior cerebellar peduncle to the cerebellum, these are the external arcuate fibers. We have other fibers also that we call the internal arcuate fibers. And these fibers. So they decussate. So what we call it?
Medial lemniscus.
Internal
medial
arcuate.
lemniscus.
Okay.
Internal arcuate fibers, these are called the medial lemniscus. Okay. So we have another sensory. What are the other sensory fibers? When we go through the lateral column. Yes, please.
Anterior posterior spinocerebellar.
So what about this one?
Spinocerebellar tract.
Spinocerebellar. Which one?
Anterior and posterior.
Which is spinocerebellar? Yes. How many spinocerebellar are there?
Anterior and posterior spinocerebellar tract.
Anterior and posterior spinocerebellar. Okay. So the anterior and posterior spinocerebellar tract. This is the posterior spinocerebellar. Yes, or anterior. This is posterior or anterior.
Posterior.
The posterior anterior cerebellar tract. What will be the course of the posterior cerebellar? It will go through the inferior cerebellar peduncle, then to the cerebellum. But what about the anterior cerebellar? What about this one? Anterior spinocerebellar. It will not go to the inferior peduncle. It will go to the cones. It will go to the midbrain. Then through the superior cerebellar peduncle, it will enter into the cerebellum. So it will go above. With the help of the superior cerebellar peduncle, it will enter into the cerebellum. So the course is a little bit different in these two. Okay. So the posterior is spinocerebellar and the anterior is spinocerebellar tract. Okay. Last fibers of this column. So what are the last fibers? Yes, please.
Spinothalamic tract.
Spinothalamic tract. How many are there?
Lateral and anterior.
Yes, anterior and lateral spinothalamic tract. This is lateral spinothalamic tract. This is lateral spinothalamic tract. When it will go? How it will go? कहाँ से जाएगा ये? Sorry, where it will go? Because I'm very oftenly use the Urdu when I use or take the class here. I use the Zoom meeting here, but I don't know that. I have forgotten that one. So anterior spinothalamic tract, definitely thalamus, then above it will go because it has the sensation. What kind of a sensation? What kind of a sensation it will take?
Pain and temperature.
Yes, Dr. Sana.
So pain and temperature.
I'm sure
Yes,
Dr. Sana
pain
is very
temperature.
happy to hear some Urdu and the familiarity that comes with it. But we have a lot of
Thank
people
you.
who don't understand it, so it would end up isolating them.
Okay.
She
So
even
thank
sent
you.
you a heart.
So it is, we have yesterday discussed that it is the conscious sensation. It is not unconscious sensation. What sensation which is related to the cortex, that it is a conscious sensation. Conscious sensation is there, not unconscious or non-conscious sensation is there. So anterior is spinothalamic tract and lateral is spinothalamic tract. We have done the sensory tracts. What about the, now we come to the motor tracts. So motor tracts anterior part, look at here, what is structure this one?
Pyramid.
Yes, please.
Corticospinal.
So pyramid. So in pyramid, what tracts it usually is there?
Corticospinal tract.
Corticospinal tract. Corticospinal tract decussate. These are the corticospinal tracts. Okay. Anterolateral corticospinal tract. Okay, posterior to this one, it is just a nuclear spinal tract will be there. And on the either side, the superior and superior lateral side, there are two tracts are there. one is here, and one is here. So anyone who can name it? Yes, please. What about this tract? Yes. What is this tract?
Tectospinal tract.
Excellent. This is a tectospinal tract. What tectospinal tract it does? What is the function of this one?
Sir, with the visual stimuli, it moves the head and neck in conjugate motion.
This is the tectospinal tract.
Descending or ascending?
Sorry? What are you saying, Dr. Mustafa?
Sir, I am saying either they are descending or ascending tracts.
Tectospinal tract.
Descending.
What it could be?
Descending. Since it's
Yes, Dr. Yusra?
descending tracks, since we're discussing motor tracks.
Why your people are confusing? Confusing me, actually. Why you're confused in between that? Is that when the tecto is there and spinal is last, it means the insertion is last and origin is first. Where it arises? Where it arises? From where it arises?
Sensories. Yeah, tactile sensation, tectospinal.
Tectum.
So
Then
it
why
will
we are
be
saying that it is the
Mm.
ascending tract? So look at here. The origin is there. That if it is from the cortex above, then it will be how it will be the ascending tract. We have discussed the ascending tract. We are now discussing the descending tract. Okay. So this is the tectospinal tract. Yesterday we have seen that what it does. It coordinates the movement, eye and head and neck. That is the conscious movement are there. When you are moving around towards the object, that is with the help of this tectospinal tract. Just later to this one, what kind of this tract is there? Yes, please.
The vestibulospinal tract.
Sorry?
Vestibulospinal tract.
Excellent. This is the vestibular spinal tract. Vestibular spinal tract, it will usually do the balance of this one. This is the oligonucleus. And oligonucleus, it has two nuclei there. One nuclei that will go toward the above, and that is the olivocerebellar tract. And other one? Yes, please.
Olivospinal tracts.
Oligospinal tract. Olivospinal, not oligospinal. There are two nuclei there. One is the superior lateral side and one is the medial side. The superior one, it will go through the cerebellum, that we call the olivocerebellar nuclei. And the medial one, that is the olivospinal tract, bilaterally here. This is the olive. Now we have remaining only 2 or 3 tracts here. What will be here? Yes.
Reticular formation.
Excellent. Reticular formation. What is the function of reticular formation?
Consciousness awakening.
Excellent. The reticular activating system throughout the whole brainstem, it is arranged. That's the function of this one. That it is the function of reticular activating system. It makes some part of the reticular activating system. So on the lateral to this one, I forgetted one tract. Anyone who remembers? Anyone who remembers? Yes, please. What is this tract? This one here. What we call it? These two.
Medial lemniscus.
Medial lemniscus is this one. This is the medial lemniscus. This is medial, but it's not lemniscus. You are on the track. Yes.
It's MLF.
Excellent. It is MLF. So medial longitudinal fasciculus. Medial longitudinal fasciculus with the help of tracts. And then which nerves are involved in the medial longitudinal fasciculus? Yes, please.
Abducent nerve, sir. Abducent.
Sorry?
Abducent nerve.
Abducent nerve. Anyone? Any other nerve?
Oculomotor, sir. Oculomotor.
Yes, excellent. Any other nerve?
Vestibulocochlear.
Vestibulocochlear, oculomotor, abducent. So with the help of MLF, this one, we have different kind of movement and coordinations there. So these are the different tracts are there. That we call it the descending tract. Last, the one tract is there. So here it will be most likely
Red nucleus.
red nucleus, rubrospinal tract. So these are the tracts. When you see the arrangement of this just nuclei, when you are memorize only the structures that are related to the nuclei, then it look at here. Then it is very easy for us to memorize these all structures when you are going anterior to posterior, or posterior to anterior, or from lateral to medial, or from lateral to medial bilaterally, or from medial to lateral. No, that's why it's very necessary for us to memorize the normal anatomy. That's topographic anatomy of any structure, any could be that is the medulla oblongata or brain. So this is all about the surface anatomy. But this is the one transverse section I told earlier. With the help of this one, we can make the 4 transverse section of the medulla oblongata at different levels. What level is there? Then that nuclei will be there. So now these are the same we have discussed, the gray matter nuclei of the rhomboid fossa on the top of this one, the cuneate, the gracilis, reticle formation, olivary nuclei, external arcuate, internal arcuate, medial lemniscus, spinocerebellar, spinothalamic tracts, anterior corticospinal tracts, rubrospinal, reticulospinal, olivocerebellar, olivospinal, medial longitudinal fasciculus, vestibulospinal tract, tectospinal or corticonuclear tract. We have discussed all these tracts, their related nuclei and little bit functions. So yesterday, here we completed. Now I will not go to the detail, or you can say the approaches towards the brainstem. Remember one thing, in this today's session, we will not go through the approaches towards the brainstem. This is a different thing. The approaches towards the brainstem is different thing. The approaches in the brainstem is different thing. One is there, the first approach to the brainstem means that what tract, what route, what corridor of the normal anatomy from external to interior to reach the brainstem. How we will touch the brainstem. This is one thing. Second, when we have approached the brainstem, how we will enter into the brainstem. These are 2 different things. One, approach to the brainstem. There is some external lesion touching the brainstem. That how we will approach. That is another thing. How we will enter into the brainstem. That is the different thing. So remember one thing: the approach towards the brainstem, and then approach inside the brainstem. How we will manipulate brainstem. We will discuss in detail in last section. We will complete the all anatomy of the brainstem. Now a little bit some structures you should know that how it will be easy for us. Okay, the brainstem. Either brainstem means I'll talk about the medulla oblongata. Medulla oblongata. This is the part of the clivus. This is the posterior part of the anterior part of the medulla oblongata will be there. This is the foramen magnum. This is the posterior part of the foramen magnum. This is the petrous part of the temporal bone. This is the petroclival junction. Okay, am I right? And this is the whole the petrous part. In the petroclival junction, we should know that what structures, when we are marking this one, what structures will be there. What structure will be then the petroclival junction? Important one here. Yes, please.
Inferior petrosal sinus?
Inferior petrosal sinus, excellent. Inferior petrosal sinus. And the petrospinotemporal bone, the superior petrosal sinus will be there. And anteriorly, there will be the basilar artery. We should be aware of it from this one. Okay, so when we see this here, the anterior part, either the corridor will be, we are using, suppose that this approach through the help of the carrion, either it's through the help of the temporal, subtemporal approach, either from here, or when we are going through the posterior approach to this one, that we call retrosigmoid approach. Retrosigmoid approach, we have to do the anterior petrosectomy when we are dealing this one. Either we have to come through the transoral approach when there is a little bit lesion at the level of the odontoid. When the lesion is posterior side, we have the two approaches mainly. Either we should go the classical approach of the fourth ventricle, that is the tilobular approach, or the Vernian approach, transvernian approach. And second one is a little bit lateral side is there. We have to go through the far lateral approach. From here, either to the midline or the far lateral approach. When the lesion is here, we can approach this one. These all approach we will discuss in detail, that what is the lesion and how we'll have to approach this one, and step by step. This is just overview. So first thing that you should know the bony anatomy and some landmarks about it. And second thing, we should know when we are going through the radiology of this one, then we should know that where the lesion is actually there, and we have to demarcate that the lesion is there. It is anterior or posterior. Anterior, posterior will be demarcated according to some structures. Look at here. There are two structures. What is this structure? Yes. And what is this structure? Yes, please. Are you guys with me?
Yes, sir.
Yes, sir.
So what is this structure? Yes. It's some kind of a tract. It's some kind of a nerve. It is some kind of a vessel. What do you think?
So tracts.
Yes, please. It's a tract. Yes, you are right. It's a tract. Very good. It's a descending tract or ascending tract?
So descending.
Descending tract. Excellent. It is in the midline or laterally placed?
Laterally? No,
How
sorry,
you can
midline.
say
Sorry,
laterally?
midline. Sir, midline hai.
How you can say the laterally?
Sir.
This is sagittal section that is you feel the difficulty. You can say this is the laterally placed, but not say this one. This is the one middle line, and this is another one. So how we can say it is a laterally? Yes, please. It's a midline tract. So name the midline tract, this one. Now it is easy for you, Dr. Sana.
Corticospinal.
No. Corticospinal tract, this is not. Another one. We have discussed that. Yes?
Pyramids? Pyramidal?
Sorry?
Pyramids?
No, pyramidal not. Corticospinal included in the pyramidal tract. Another tract which is midline placed. We have
Olivary?
discussed yesterday. Rule of 4.
Medial longitudinal fasciculus.
Excellent. This is MLF. medial longitudinal fasciculus. Medial longitudinal fasciculus, MLF. So one demarcation line, it is the medial longitudinal fasciculus. The lesion that is anterior to this one, it is anterior. The lesion that is posterior to this one, that will be the posterior. So the lesion that is anterior to this one, we will approach the anteriorly most likely. The lesion posterior to this one, we will approach posteriorly most likely. So this is one thing that we have to see, that it is the medial longitudinal fasciculus. And second, what about this one? Yes. This is coming from the bones, from here. So I will move to the next figure, then it will be easy for you. Yes. Yes, please. Yes, please. What is this tract? What is this one? Am I audible to you people?
Yes, sir.
So what is this tract?
Fasciculus gracilis anconietas.
Sorry?
Fasciculus gracilis anconietas.
No, fasciculus gracilis and not cuneatus. This one. This is descending tract. And second thing, look at here, it is anteriorly placed. It is not posteriorly, so it could not be the fasciculus gracilis. It's not sensory one. Trigeminal? Yes. Yes, please. What is this one? This is the trigeminal nerve. This one. Trigeminosspinal. So again, there is this one. This tract is important. It is anterior and the posterior. This one. There is a school of thoughts where it is lower one in the posteriorly, we can approach posteriorly, but it's little bit more anteriorly. That will be difficult. This is one school of thought. This is one parameter that we have to see the tracts are there. What tracts are involved? But there's another one. Second thing is that we have to see the vascular supply of the medulla oblongata. We know. What is the vascular supply of medulla oblongata? Yes, please.
The medulla oblongata is supplied by the anterior spinal artery, pica and ica, and superior cerebral.
Yes,
yeah,
excellent.
Artery,
you are right. Most likely the posterior circulation, the vertebral body, vertebral arteries, some part of the pica most likely supplies. We should know. Then we are going through this one, then we should know that where it actually lies, that we should be careful about that. We will not use that corridor, that in which the vascular structure, any kind of these three vessels, anterior spinal, some branches of the vertebral, most likely the pica, and some portion of the ica when we are going superiorly. So we have to know about this one. Then we will decide that what corridor we will use. So when we talk about the safe entry zones inside the medulla oblongata, there are three safe zones are there. So I will try to describe this one. This is the anterior surface. This is the posterior one. This is the transverse section of this one. So what is this? We know very well. This is pyramid. This is olive. This is olive. Trans-olivary approach could be there when we are approaching the lesions through the anterior part of this one. This is same like OZ. This is olive. Okay, this is dashed lines. And second thing that we can use the anterolateral sulcus could be there, but not superiorly. This is the anterolateral sulcus, but not go to the superior side. Why? Why not go superiorly? Because there is a 12th nerve is there. We have to be careful about that. We should be careful in the when we are dealing the you can say the brainstem, three things. One is the nuclei and tracts, vascular structures, and the tracts are there. Three things: nuclei, tracts, and the vascular structures. We should be careful. When we are doing this one, here there is a safe zone. There is no any vascular structure, most likely. There is no any tract, most likely. There is no any nuclei. Only the nuclei are superiorly placed. That is the 12th nerve nuclei. That's why it's the safe entry zones inside this one. Second thing, the posterior median fissure. We can use the posterior median fissure safely. When the lesion is posteriorly placed is there, with the help of tellular approach, we can use the posterior approach. And this is the ALS. What's it mean by ALS? Anterolateral sulcus. We have discussed earlier that anterolateral sulcus, this anterior approach, when we are laterally doing, we can do the anterolateral sulcus or transolivary approach, or the posteriorly dealing, we have to use the posterior median sulcus. And what about this one? What about this one? We have discussed in the posterior dorsal surface that same like in the anterior surface, this is the posterior lateral sulcus also there. When anteriorly here will be the olive and the here will be the nucleus cuneatus, and this portion will be the inferior cerebral peduncle. Here, little bit portion will be the inferior cerebral peduncle. This is the middle cerebral peduncle. So we can use this corridor as well. When we are using the anterior little bit, this lateral approach, our target will be, this will be our target. When the lesion is here, we can use the anterolateral approach, this one, because the lesion is anteriorly placed. In anterolateral approach, we have two approaches. Either we should go for the transolivary, or I should go the ALS. And this will be the incision of this one. Look at here. And the lesion will be here. Okay? Got it? Any confusion?
Yes, sir. No.
So in medulla oblongata, we have three safe entry zones. 12, we have overall 12 to 13 entry zones in the whole brainstem. For medulla, we have only three safe entry zones. Most likely, either we should go for the ALS, anterolateral sulcus, transolivary, or in the posteriorly we can go for the posterior median sulcus, But when there is a posterior lateral lesion is there, we can go through the posterior lateral zone. That is the little bit posterior and inferior to the inferior cerebral peduncle, this area. But most likely the posterior median sulcus, the transolivary or the ALS, and the transolivary approach, this is the safe entry zones. We can enter inside the medulla oblongata. How we go inside and what lesions can be assessed and approached, and how much surgery we can do, what is the limitations. This all we will discuss in detail when we are discuss the approaches. So up to here, any question?
No, sir.
Yes, please. If you have any question, you are welcome. Then otherwise we will conclude this one. And tomorrow we'll start the poems. This is next. I have already made this one.
Dr. Itzaz, I wanted to ask if wouldn't this be a good idea if we proceed to the medulla surgical approaches first, because the anatomy is very fresh, the safe entry zones are also very fresh, and then if we move on to pons, then they will, sort of mix it up. So what do you think would be a better approach?
First, it is up to you.
You can just ask
because
them.
and
Let's see
then
what
it's
they say.
up to the participants if they want that we have to discuss the all approaches of the medulla oblongata from outer side to the inner side, that how we have to approach, what are the different approaches. We will discuss it. Uh, but if they want that in the last all approaches simultaneously we have to discuss,
I think they'll
including the
forget it
mid-brain
then.
bones.
The anatomy is very fresh, and if we follow this up with the approaches, they are going to retain it better.
Okay, if they
We can
agree,
just leave a
I
poll
think,
on the group, maybe.
okay. Put this question and this suggestion in the group. If all they
Hi,
are agree, then tomorrow we will discuss the all approaches of the medulla oblongata. Approaches means
okay.
including approaches all. That is either sub retrosigmoid approach, that is the Syrian approach, what structures could be, what lesions could be assessed, that is the anterior petrosectomy, that
I
how
really,
we will.
really doubt if we would be able to complete that one on time if we are discussing the safe approaches towards medulla and then the approaches within the medulla. I am 100% sure you would not be able to move even beyond terional. So we can discuss the medulla approaches first, maybe the safe surgical corridors, and
Okay.
then the approaches towards the medulla can be discussed later on in a separate session. Otherwise, it would
Then it's
probably
good. It is okay.
cross more than 60 minutes.
Okay, all right.
And I think we should divide sessions per approach. If you actually want to do justice to them, we can cover terional in one, we can cover retrosigmoid in one. I am very sure that you would not be able to do justice
No,
to
all
them.
approaches they are very lengthy. Anterior
Yeah,
petrosectomy,
exactly.
retrosigmoid
And they are
approach,
all of them are very
perineum
important. They are
approach,
the bread and butter
then
of,
yes,
yeah.
endoscopic approach. What endoscopic approaches could be there? So these are all. It will be a lot. So
I
just
think this week we can focus on medulla in terms of the safe surgical
okay.
approaches, and then we can maybe include one session on terional and one session on whatever retrosigmoid if you want to do. Then we are set for this week, I think.
I will make different cases regarding the
Okay,
medulla oblongata.
okay,
The any cases of the anterior, any and the posterior side, and then
okay,
we will discuss upon that one, that how we'll approach this one and why we will approach this one. Okay,
okay,
that will be
okay.
easy. That will be quite
Okay, so
easy.
maybe we can focus on medulla this
Yes.
week,
Okay.
and then we can
All
start
right.
with the pons in the next week.
Okay. Okay.
Okay,
That's fine.
okay, everyone.
Thank
Thank
you
you so
all,
much.
the audience and participants. Thank you, Dr. Kumar.
Thank you, Dr. Itzaz. Thank you so much, everyone. I'm going to leave a poll on the group, and you all can vote. And let's see how we take it from there.